Доброго ранку, шановні учасники.
Good morning, dear participants of our meeting today.
Доброго вечора, наші
Good evening, dear colleagues from Australia, because today it's 7 p.m. in Australia and 10 a.m. in Ukraine. My name is Irina Pinchuk. I am the director of the Institute of Psychiatry of Kyiv National Institute, named after Taras Shevchenko. Also, I am the vice president of the Association of Psychiatrists of Ukraine, and today I will be the moderator of our meeting. I welcome all the participants of this seminar. This seminar today is dedicated to getting to know the system of health in Australia. Dr. Vinay Lakra, the president of the Royal College of Psychiatrists in Australia and New Zealand, will tell us about the model of health in Australia. This event is in the frames of the implementation of the National Mental Health and Psychosocial Support Program, initiated by the First Lady of Ukraine, Olena Zelenska, with the support of the World Health Organization, in partnership with the Working Group on Mental Health and Psychosocial Support of Ukraine, and in the frames of the cooperation between the Association of Psychiatrists of Ukraine and the Royal College of Psychiatrists of Australia and New Zealand. This seminar is the second seminar, the series of the seminar in terms of getting to know more about the system of mental health in different countries. Previous event took place August 16 this year, and it was about the experience of the system reform and the service of mental health in Belgium. Each of you will have the possibility during this seminar to ask questions. These questions you may write in the chat or ask them after the presentation. Also, I'd like to say that there is the interpretation of this webinar. In the settings, you can find the interpretation, and you can choose the necessary format, be that Ukrainian or English language. Also, I'd like to say that the safety and security is the priority, and if during this webinar there is something unexpected, some unexpected situations we may face almost every day, then each and every one of you, first of all, has to go to a safe place. Since today, a lot of people could not join us because of the internet connection problems, our seminar will be recorded, and each and every one of you will be able to look and watch it again. Now, I'd like to give the floor to the Deputy Minister of Health of Ukraine, Irina Makitchak. She is here with us today. Mrs. Irina, please, the floor is yours. Welcome. Thank you so much, Mrs. Irina. Hello, dear colleagues. It's very pleasant that today we have a very nice community of interested people, interested specialists who put efforts, knowledge, skills for all of us together to be able to provide maximum professional, good quality service and aid to our people. The war which the Russian aggressor conducts against Ukraine destroys not only hospitals, houses, and our infrastructure, energetic infrastructure, but takes the lives of our people, our defenders, who keep the sky over us free of rockets and missiles, but the war also destroys and affects mental health of Ukrainians and all the people who empathize what's happening here in Ukraine today. And it's really important for all of us to create a really acting and effective system which will enable to provide psychological aid to every person wherever that person is and needs it. We actively participate as the Ministry of Health in the cooperation with the Office of the First Lady of Ukraine, Olena Zelenska, and with our partners, reliable partners, the WHO and other international partners, information of the National Mental Health and Psychosocial Support Program. This program, thanks actually to the initiative of Olena Zelenska, the question of mental health has raised to a very high level. There is a very high bar for actually making real changes. Traditionally, it was seen that mental health is the area of psychiatrists, and people who have problems have to go to psychiatrists. But we are aimed at doing something important to give people the possibility to receive psychological aid from good quality specialists, psychologists, psychotherapists, specialized aid, primary care line, which contacts people the first when there is the health problem. Mental health does not have visible points and complaints which people can come with, and there are a lot of stigmas and barriers to come for the necessary help. And thanks to our intersectorial cooperation, we can help people a lot and change this aid provision and system of mental health in Ukraine. And taking advantage of the opportunity, I see a lot of colleagues here who represent not only health institutions and health area, but also other departments. I mean, the defense block, education, social block, the Ministry of Social Policy, specific departments. This cooperation is highly important for us to help and provide real help. And we cannot create good quality service, psychological aid, specialized psychiatric aid without engaging and without learning and processing international experience. I want to thank Irina Pinchuk and the Association of Psychiatrists of Ukraine for the initiative in contacts with the International Scientific Professional Society of Specialists on Mental Health. And really, we had earlier a similar seminar with the help of the WHO with our Belgium colleagues. Apart from that, there was the work visit to Belgium, where the specialists, our specialists from different ministries and NGOs managed to communicate with the team realizing the reform of mental health in Belgium, which has been lasting for 12 years. And we tightly cooperate with the colleagues from the Ministry of Health in Poland, who are on the first stage of the reform of psychiatric aid and the service of mental health in Poland. And thanks to the agreements of Olena Zelenska and the Princess Catherine Middleton, we had agreements with the British colleagues, with the associations and the representatives of the National Health Service of Britain about the first experience of work with the experience of the UK, together with the Association of Psychiatrists of Ukraine, with the WHO and Swiss Ukrainian project Mental Health for Ukraine. We plan to introduce the session of traditional meetings, seminars with our international partners and colleagues who have long-time experience of transformation, psychiatric aid, deinstitutionalization, fighting stigma and implementation, modern evidence-based protocols of psychiatric aid provision. A lot has been done this year by the Ministry of Health of Ukraine to make the psychiatric service more humane and accessible for people, but it's only the beginning of our way. And we really hope for cooperation. And today, this is very huge honor to communicate with our Australian colleagues today. A few years ago, I had the possibility to communicate with Australian colleagues on reform in general, and I think that today we can hear a lot of useful information. I can say that both British and Belgium colleagues during our meetings mentioned the experience of Australia in providing psychiatric area and in the area of mental health. That's why I want to welcome all of us to listen attentively to the speeches and the presentations and actively participate in the discussion. And I do hope that our armed forces of Ukraine will make this day calm and not to go back and take a lot of time. I want all of our medical workers and all of our partners and colleagues from other departments and institutions, foreign colleagues, I want to thank for these 300 days of our resilience and fight and the enormous efforts in medical frontline in fighting with the Russian aggressor. I want to thank our partners for being with us physically, with their experience, humanitarian aid, and I want to congratulate everyone with the upcoming Christmas. I want to wish all of you health and victory. Thank you. Thank you so much, dear Irina Mikitchak, for such warm and kind words and powerful support of our service in the Ministry of Health. We are so glad to have this support, and we really hope that the next year will also be very interesting for the development of our system. Thank you, sincerely, thank you. Thank you so much, Irina Pinchuk. I'd like to say one more thing. It will also be a very interesting and fruitful year, since yesterday with the minister we signed the agreement with the World Bank for the funding of our joint project with the World Bank for the next 5 years. And for the 2 years, 2023-2024, this funding will be 110 million euros. And I'd like to congratulate all the society working in mental health and say that the first component of this joint new project on the preservation of health system in Ukraine is the component of mental health. That's the first time we receive such huge investment which will be aimed at the mental health of both educational programs and reconstructions of psychiatric inpatient departments, ambulatory centers of mental health creation. So there is a lot of work ahead of us, and the initiative of every single person is welcomed, and we will speak more about it next year. Thank you. Thank you so much, Irina Mikitchak. Let me now invite our colleague from Australia, the president of the Royal College of Psychiatrists in Australia and New Zealand, the associate professor of University Melbourne Psychiatry Department. Today, this is the first day of Christmas holidays, but despite this first holiday day, Dr. Vinay Lakra agreed, and today he is here with us. Please, Dr. Vinay Lakra, the floor is yours.
Thank you, Olena. You can hear me? You can hear me. Okay. Thank you. I learned something new. I did not know about the interpreter service in Zoom. So sorry, I missed the initial part of your presentation. And then when I was fiddling through it, I realized that there was something which would have helped me understand in English. So I heard the last part of it. So really, thank you for inviting me. Our thoughts and prayers are with everyone in Ukraine. As you know, there are many colleagues who are in Australia who have connection and ties with Ukraine, and many of them are doing everything possible to support people there. I also want to say Merry Christmas to everyone. Yes, it is difficult time, but we know that difficult times don't stay forever, and we need to remain optimistic and hope that your efforts will bear the fruit. And I really want to thank Irina for making this happen. I will share some slides and I'll talk a little bit about our experiences of mental health system here in Australia. Now, I must say that when it comes to mental health, most countries have lots of difficulties. And so, uh, in no way I'm saying that Australian mental health system is better than many other systems. Every system has its own problems. And in fact, one of the previous directors of mental health at WHO had mentioned when it comes to mental health, all countries are developing countries. Because we know that many of our patients with schizophrenia, bipolar disorder, they die 15, 20, 25 years earlier than the general population. And it's same in all countries, including in Australia. So there are opportunities for us to learn from each other. There are things we are doing well, and there might be things which you are doing well or other countries are doing well. And I think in that context, sharing this information with everyone, this is a great opportunity. So really, I want to thank Irina for starting this dialogue and having this conversation. I was able to listen to some of the presentation from Belgium, and that was very, very helpful. So I'll share my screen. Okay, you can see it? Yes?
Yes.
Yeah?
Yes.
Okay. Okay. Oh, good. All right. So before I start, I completed my training in India. So I finished my medical training in India, and then I completed my psychiatry training in India. I worked there for 2 years before I migrated to Australia. And I still remain connected with many colleagues in India and many other countries as well. So I have a fair bit of understanding of different healthcare systems. And if there's one thing I can say is that working in more than one health system is a very useful thing to do, because what it does is it allows you to understand the benefits of various healthcare systems. So I think having that experience of working in India and now in Australia and those connections certainly helps me understand what we're doing well and what we need to do better. Okay. So for those of you who might not be aware of where we are located, we are in the Far East. We are in what is called as the Pacific region, both Australia and New Zealand, surrounded by many other countries, including Indonesia in the north, Papua New Guinea in north of us, and there are some many island countries between Australia and New Zealand, including Fiji. And so we are roughly, in terms of flying time, we are around 24 hours of flying time from Melbourne to Europe. Briefly about the college. So the Royal Australian and New Zealand College of Psychiatrists is responsible for training, educating, and representing psychiatrists in both of these countries. I think we are probably one of very few, or maybe the only association which represents two countries. So we try and put equal efforts into supporting things in both of our countries. We are also very similar to the Royal College of Psychiatrists in UK in the sense that we look after training program as well. Many other psychiatric societies are not necessarily responsible for training. They advocate and they represent psychiatrists, but the training is managed by various universities. Whereas in Australia, the medical training is managed by the universities, but postgraduate training is managed by specialist colleges. And so our college manages postgraduate training for psychiatry. We have around 7,793 fellows currently. That number continues to grow. Majority of them are in Australia. Australia is there are multiple states and territories in Australia, so they have their own legislation as well. So we've got three tiers of government in Australia. There is the federal government, then, or what we call as Commonwealth government. Then there is the government in each of the state or territory. Western Australia, Northern Territory, I am in Victoria, in Melbourne. So each of the states have their own government. And then we also have a third tier of government, which is the local councils. So each of the state has multiple local councils, and those council bodies elect their own representatives. And so they are responsible for certain services as well. So there is a three-tiered approach in terms of government. And in a similar way, there is a three-tiered approach to health and related issues as well. As I said, we support training, and so our trainees are located all across Australia and New Zealand. A majority of them are in Australia. There is also quite significant reliance on overseas trained doctors, both in Australia and New Zealand. More so in New Zealand, they have committed to doing more about their health workforce, including medical workforce, but there still remains quite significant reliance on people coming from overseas. In fact, roughly a third of doctors in Australia have trained overseas, and in New Zealand, that number is around 50%. So there's been a lot of pressure on the governments to make sure that they can increase the number of training places in medical schools as well as specialist training. So that's one of the key issues in terms of workforce for both Australia and New Zealand. So as I said, the college is the peak body representing psychiatrists in both Australia and New Zealand. We have strong ties with associations in Asia and Pacific region. We are a member of what is called as Asian Federation of Psychiatric Association. Similarly, I think in Europe, there is a European Psychiatric Association. So similarly, in the Asian region, there is the Asian Federation of Psychiatric Association, and we are a member of that association. We, as I said, are responsible for training psychiatrists in Australia and New Zealand. We also, those psychiatrists who completed their training overseas, we also assess their training as well to see how comparable that is to an Australian trained psychiatrist, and have a program or a pathway for them to complete whatever they need to do to be recognized as a specialist in Australia. The training program is accredited by the Australian Medical Council and the New Zealand Medical Council. They are our regulatory bodies, and we also offer an affiliate membership and as well as an international corresponding membership. So many people who are overseas, they can access our international corresponding membership. It provides access to continuing professional development and many other resources on our website. Quite a few things we do. We set the professional standards for practice of psychiatry in Australia and New Zealand. We, as I said, we manage the training program. So we conduct the training and examination for doctors who want to qualify as psychiatrists. So we complete all of that process as well. We administer a continuing professional development program for practicing psychiatrists. Continuing professional development is mandatory for all doctors in Australia and New Zealand. And so they need to complete their training, CPD, and there are regular audits, but essentially we run a CPD program for our members. We also organize conferences and meetings. Our annual conference is in May. Next year in May, our conference is in Perth. And so that's our main event. We also run some meetings. Now with the pandemic, we've been running some virtual meetings as well. The meeting in May in Perth is in hybrid mode. And we also publish two college journals. There is a journal of Australian New Zealand Journal of Psychiatry and Australasian Psychiatry. So both the journals have reasonable scientific rigor, and they have a slightly different approach, and that's why we maintain both the journals. We also publish lots of policy guidelines and documents, and then we also have a public-facing website called as yourhealthinmind.org. That website provides information about common psychiatric disorders in lay terms, so that the general public can access information which is reliable for them. And then, of course, the college represents psychiatrists with the governments and various community groups and the healthcare worker groups. The college is governed by a board, which is elected directors. I am the president of the college currently, and we've got some key constituent committees. They all report to the board. There are a large number of committees, and all of that work is done by volunteers. Like any other psychiatric association across the world, all of our work is done by our college members, and that is done through volunteer process. We also have a branch in each of the state and territory in Australia, and we also have an office in New Zealand. And then we've got various other faculties, sections, and networks. For example, we've got faculties in child and adolescent psychiatry, old age psychiatry, consultation liaison psychiatry. And then we have some sections for specific areas of interest. We've got a section for electroconvulsive therapy and neurostimulation. We've got a section for perinatal mental health. So depending upon the need and request from members, we do form certain groups to advance our agenda. And then on top of that, we've got a members advisory council, which is a large body, in a sense that it has the chairs of all the branches, faculties, sections, and networks. And that council provides guidance and input to the board. The board has 8 members. We have a trainee on the board, and then there are 7 psychiatrists on the board. So as a college, what do? Really, we get involved in anything related to psychiatry and mental health, policy-related issues, clinical guidance. We advocate quite strongly for social determinants of mental health and well-being, as well as health. We advocate for homelessness issues, loneliness, poverty. We've been doing some work around climate emergency, and certainly we also release statements about various things, including various crises which are happening around the world. How do we advocate for things? We engage with the governments and policymakers. So each of our binational college, as well as each of our state offices, they are very well connected to the respective governments. We provide lots of policy submissions, and in fact, many of these resources are available on our website. So if you visit our website, there is a lot of information which is publicly available. You don't need to log into the website. It's easily accessible, including our various guidelines and resources. We also develop some advocacy reports. For example, in recent years, we've developed advocacy reports around affordability in psychiatry, physical health of people with mental illnesses. So various reports which are helpful in addressing some of those issues. And then we are also able to provide members who represent us on various government committees. So that's another way for us to advocate and be involved in changing the system. And as I said earlier, we release quite a few media statements depending upon the issues at hand. I want to share a few more things before I delve into the mental health system in Australia. One of the things about mental health is really this whole issue that of inequity in delivery of mental health care. And this is some work which was done in Australia, where they looked at percentage of the population with very high K10. K10 is a scale which is used to measure psychological problems. And across poorest areas and then richest areas. And if you look at that graph, those who live in richer areas, they have lower rates of psychological problems, but they access more health services. Whereas those who live in poorer parts of the society, they have more mental health problems, but they access less. So there is this issue of inequity. And I think this exists in the entire world everywhere. If you are richer and you have better resources, you are less likely to have mental health problems, and you are more likely to access help. But if you are poorer, then you are more likely to have mental health problems, and you are less likely to be able to access and afford help. So that's really fundamentally talks about social determinants of mental health. And that's why I said that these issues are pertinent in Australia as well. In the last few years, we've had lots of inquiries in mental health. So, we haven't got it all right. Last few 5-7 years, there's been a number of high-profile inquiries, and we provided input into many of these inquiries. One of the highest form of inquiry in Australia is called as Royal Commission. And the government establishes a Royal Commission with its terms of reference and appoint commissioners who then have conduct the inquiry, and it has a very strong basis in terms of its impact. And so there have been a recent number of Royal Commissions and other inquiries on, there's one happening currently on defense and veteran suicide. There was a productivity commission inquiry into mental health a few years ago. There's an inquiry into New Zealand government. There was an inquiry here in Royal Commission into the Victoria's mental health system. So what these inquiries have done is they've kind of put the mental health agenda right in the front and center of all the governments in Australia and New Zealand. Because of these significant inquiries and in various spheres, defense and general mental health, aged care, safety and quality, abuse and neglect of people with disability, what it has done is it actually really highlighted the importance of whole of government approach to addressing mental health issues. And so, yes, it has taken a lot of time and effort from everyone, but we are also hopeful that some of these inquiries will actually help us improve our system. This is a list of various other inquiries we've been providing submissions to. So we've been very, very busy, and I don't expect you to read everything, but it just gives you a long list of various inquiries and various issues which relate to mental health, including things like review of the mental health legislation, or voluntary assisted dying, or reducing restrictive interventions, or addressing mental health issues for people with Aboriginal and Torres Strait Islander population, like that's our indigenous population in Australia. So a large number of inquiries and investigations to which we provided responses to. Let's just talk a little bit about the magnitude of the mental health problems in Australia. So 1 in 5 people and 1 in 7 young people experience a mental health disorder in the previous 12 months. So this is most recent data. We recently had a mental health prevalence study of what people experience in the last 12 months, 21-22. And so this is from that data. 5% people are expected to have a severe mental illness. So when I talk about severe mental illness, I talk about people with schizophrenia, bipolar disorder, severe personality disorder, severe depression, or those who have more severe and disabling anxiety disorders. So around 5% of Australians have a severe mental illnesses. Anxiety disorders are the most common, affecting 1 in 6 Australians. And mental health and substance use disorders were the second largest contributor to non-fatal burden of disease in Australia. So it's quite significant when you look at it. This is some data from the Productivity Commission's inquiry, and what they looked at was the prevalence of mental health, mental illnesses in developed countries, and there's an OECD average. Now, I know that it is difficult to compare different countries and health systems because this prevalence depends upon healthcare literacy, it depends upon stigma, it depends on what people report or what do not report. But still, it gives us an opportunity to see what's been happening in various countries. And if you look at it, in New Zealand and Australia, the prevalence for mental illness is very high, around 18%, 17%, compared to other countries in Europe and America, certainly higher than the OECD average. So I don't know what it means. You can interpret it in very different ways. We could say that we are more aware and more informed of problems with mental illnesses, and that's why more people seek help, and more people are able to tell us about that. It might also mean that when you look at Australia, New Zealand, United States, they are a very these are the cultures which are very individualistic in nature rather than collective family-oriented culture. And so it might be that that's an indicator of why the prevalence rates for mental illnesses is higher. But I think it's important to put that into perspective. Interestingly, you look at Singapore and Japan, which are very family-oriented culture, more collectivist cultures, and the rates of mental illness is lower in those countries. But as I said, there might be many other factors which contribute to this data. Australia spends a lot of money on mental health. So some of this data is not more recent. It's from 2019 to 2020. So around $11 billion, or when you look at the total population, around $431 per person was spent on mental health related services in Australia during 2019 and 20. 7.6% of the government health expenditure is spent on mental health. I think we've talked about around 11% of the morbidity is related to mental health. So we would want that number to go up, but it's around 7% of the 6% of the government health expenditure on mental health, 6.7 billion by the state and the territory mental health services. As I said, each of the states have their own mental health services. And then, of course, money is spent on the public hospital services as well as community services. And then the Commonwealth government, or is the Australian government, what I call as, they spend around $1.4 billion on Medicare subsidized mental health services, which is basically to access psychiatrists in private practice or psychologists or GPs, so through, like, essentially like primary health care. And then, of course, there is money spent on mental health medications as well, because Australia has got a subsidized system of providing medications. So I think access, I just already mentioned that from that study, 2021, not 21, 22, 2021, around 3.4 million Australians saw a health professional for their mental health in the previous 12 months. That's a large number when you look at it. We've got a population of around 25 million. So around 3.4 million people saw somebody from that age group. So if you look at the age group, then it might be even actually a smaller population. So there is a large population which is seeking help. Of those with a lifetime disorder, 38% saw a GP. So that's our basically the first point of access for a lot of people when they want to go and seek help for a health problem or for a mental health problem. 22% consulted a psychologist. They can see a psychologist if they get a referral from a GP. So the Medicare supports that, and then 8% saw a psychiatrist. Around 860,000 Australians access at least one digital service for mental health, such as crisis support or treatment programs or information. There is quite a bit of resource around digital mental health services, websites and things like that. That's a little complicated graph. It just talks about the Australian healthcare system. And so if you look at, you start from outside and you go inside, what you'd see is that there are various community related things, family and community, rural and remote, income issues, employment, education. Then you move into things which are related to health promotion and disease prevention, physical activity, illicit drug use or smoking or alcohol, well-being. I would rather not use the word mental health, but I'll just talk about well-being, cancer screening. And then the third tier really is primary health and community care. Primary health is really a general practice. So there are general practices across the country. And so most people would access healthcare from a general practitioner. Once they access general practitioner, the general practitioner can then refer them to a specialist, or they can also refer them to see a psychologist. And these services are reimbursed through the government. The healthcare provider can decide to not charge anything and just receive the reimbursement what the government provides, or they can charge a gap as well. In fact, a lot of people actually charge a gap, and so there is an out-of-pocket expense for the patients and their families. And the last tier really is the specialist acute health services. So that's where our hospitals, and specialist services are there. That includes pathology and various other things as well. So there are these multiple tiers, right from things which are done at addressing the social determinants of health and well-being to right from the highest point of care for specialist health services. And then, of course, there are other elements in it in terms of who funds that money, how does that funding gets divided up, what's the workforce which is available to provide care, what sort of infrastructure is there, and what are the other opportunities in terms of technology and chronic disease management and things like that, which are available to deal with that. I'm very happy to share these slides, so please, you don't need to worry about that. Then this is a slide which kind of talks about, again, a bit more about how the money is spent. So if you look at the central circle, you see 40% money goes to the hospitals, 38% goes to primary care, and 22% goes to other services. Then the second circle, if you look at it, is who's responsible for these services. So the hospitals are public hospital services, which are managed by the state governments, and the private hospitals, which are funded through the private health insurance. And if you look at primary health care, that includes community and public health, dental services, medications, medical services, which are non-referred, basically the GP or general practitioners, and other health practitioners and medical services that are referred when you're referred to see a specialist. So that gives you that distribution, how you can distribute that. And the last, the outward circle, is really where the money comes from. So which part of the government spends that money. So for example, if you look at the hospitals, 40% of money goes to the hospital, and only a small proportion of that money comes from the Australian government, whereas a significant proportion of it comes from the state and territory governments. And there are agreements in place between the state and the Commonwealth government to address some of these funding arrangements, but they are quite complicated. There are two major inquiries in mental health which have happened in the last 5-6 years. One was a productivity commission, which was initiated by the Commonwealth government, and second was a royal commission into the mental health system in Victoria, where Melbourne is located, is the capital of Victoria. So these two inquiries have actually provided quite significant recommendations in terms of how the system should look like. And so this figure is from the Productivity Commission inquiry, which talks about building a person-centered mental health system. What should a person-centered mental health system look like? And so providing healthcare services, you look at that little corner of recovery-focused healthcare, is just one small part of building a person-centered mental health system. It involves prevention and early intervention, so early childhood and schooling, social inclusion, suicide prevention. Many of these things are not related to healthcare system directly, but they influence healthcare system, and they influence the outcome and access. Similarly, training and workplace for people, various enablers in terms of how those services can be enabled, and then services which are not directly related to healthcare, but in the fringe of healthcare, psychosocial support available to people, housing issues, or criminal justice system. So I think building a person-centered mental health system requires a lot more than just providing healthcare services to them. If we are really serious about addressing some of the challenges around mental health, I think a lot of solutions lie outside psychiatry. They lie in childhood services or support services. We now know that minimum income for everyone is a very important indicator of their mental health, as well as has its impact on suicide prevention. And then similarly, from a similar report, it talks about how we should work together to support recovery. And so if you look at the left side bar, it ranges from people which is preventative care, so they don't really need anything, but if they have good education and good employment, then they are likely to stay well and seek help and things like that, to next level being self-management, where you only provide resources to them. So somebody who's a bit stressed, you provide information to them about how they can manage stress or what they can do to look after themselves. I'm sure you're familiar with things in during the pandemic. There was a lot of emphasis on what people could do to look after their well-being. So a lot of information got shared. And then, low intensity care, where people can receive online treatment. As you know, there has been some work across the world, including here in Australia, about online CBT, that you can actually access CBT in a structured way through an online program. So some of that is low intensity care, and then moderate intensity care for people who have more severe or moderate illnesses, and high intensity care people who require, treatment for things like schizophrenia, bipolar disorder, severe depression, where they require professional care, and they require more support from other people, and the highest thing at that level is really the inpatient services and the larger care team, or the chronic disease management, what we talk about. So really, it's a stepped care model. I think the stepped care model has been talked about in the literature a lot. It looks fantastic on a piece of paper, but unfortunately, when you look at it, how it works in practical sense, there are challenges around it. And this graph again describes the same thing. So, you start with people who need various level of resources, and their problems can be addressed in a stepped care model, so that only people with severe mental illnesses, they receive secondary and tertiary mental health care, whereas a lot of people who have just a well-being issue or stress or whatever, they can be supported by self-help resources and support services. I've mentioned this before. We will never have enough psychiatrists for everybody. And I don't think we need to target that as well. We need to work out who needs what kind of support. So when I say that people who have with schizophrenia, it doesn't mean that they need to go through this cycle of self-help and online and whatever. What it just means is that if you have a severe mental illness, you access care at the secondary and tertiary level straight away. You might benefit from other resources, but you access care straight away at the tertiary level. So I think that is something which is really the need for the day, to identify what the needs of people are. Because when you look at high rates of prevalence of mental illnesses, when we talk about 1 in 4 or 1 in 5 in the population, it's literally impossible to provide care to everybody. And I don't think everybody requires that level of care as well. A lot of people with milder disorders can benefit from information, they can benefit from self-help resources, they can benefit from access to websites which can provide information for them. We also know that the rates of placebo response on milder disorders are very, very high. Many of them are self-limiting in nature. So I think it's just recognizing that fact. Essentially, again, the as I mentioned, the 3 levels of government. So the Australian government, what it does, the state and territory governments, what do they do, and the local governments, what they do. So Australian government, is responsible for Medicare. That's their main thing. So that's basically outpatient services which are funded by the Australian government, and they also runs a subsidized scheme for medications. And then they fund a range of other resources as well. They support access to private health insurance and things like that. The state and territory governments, they manage public hospitals. So if somebody requires admission to a hospital, that hospital receives funding from the state government. Or if they go to a private hospital, then it is through the private health insurance. And state governments are also responsible for ambulance services. They manage complaints and a range of things. Plus, in mental health, each state has their own mental health act. So they do that. And then the local governments, they look at mostly environmental related things. And they might provide some community or home-based services like vaccinations and stuff like that. There are some elements which are shared between the Commonwealth government and the state, including regulation of health workforce, education and training of health professionals, regulation of pharmaceuticals. So they do quite a few things in joint collaboration as well. And again, this is a slide which is a bit kind of more simpler display of how how those resources are distributed by different governments. So if you, again, what the Australian government does, what the state and territory government does, and what private and community sector does. So I think there is quite a bit of collaboration between the Australian and the state governments, and so they work together quite closely, not without its own challenges. The mental health system, again, it's on in the very similar line. So the Australian government and all state and territory governments, they share responsibility for mental health policy and also provision of support services for everyone with a disorder. The government funds primary care, which is the Medicare, and they also fund quite a few other services as well. Whereas the state governments, they provide specialist mental health services and some psychosocial support services like disability services. And they are monitored and coordinated through nationally agreed strategies and plans, as I've kind of already mentioned. The number of policies and strategies which have been in place over a long time, and the two levels of government work together on it. So there's a national mental health strategy. We've had national mental health plans. They are 5-year plans. We are currently in the process of developing our 6th national mental health plan. And then we've got also a number of other strategies. So recently we finalized a national medical workforce strategy. We are about to finalize a national mental health workforce strategy, looking at, psychiatrists, psychologists, nurses, other allied health and lived experience. There is currently a strategy about stigma and discrimination reduction in place. And then, of course, there are mental health legislation. When these strategies are developed, they are contributed by the government at the Commonwealth. They also receive input from each of the state health departments, and they are also receive input from the general public and professional organizations. So as a college, we provide submissions when these strategies are developed. We also provide members who sit on many of these committees. And so we contribute quite significantly to this process. And again, this is a bit of a timeline of something which started in 1992, the first national mental health policy, and then how it evolved over a period of time. And if you look at the number of things being done in 2020 and 2021 has grown up quite significantly. So the pandemic has really identified the need to focus on mental health in addition to the recent 2 inquiries. And so that's why there's a lot of focus on many of these things over a period of time. I think I've already mentioned about this. So what the Australian government funds, and they also fund various other things, including income support. So one of the things which happened in Australia during the pandemic was that the government was able to provide income support for people who lost their jobs. And as a result, Australia was one of the few countries where suicides actually dropped during the pandemic. They didn't drop quite significantly, but they dropped a little bit, despite the fact that many people were predicting that the suicides will go up in Australia. And then, of course, the Australian government also provides support for various other services as well, including running what is called as a National Disability Insurance Scheme. State governments, as I said, they deliver specialized mental health care through the public acute and psychiatric hospitals. They also fund community mental health care services. So I manage a mental health service in north and west of Melbourne. We serve a population of around 750,000, and I've got around 75 acute inpatient beds. I've got 20 subacute beds. I've got 40 residential rehabilitation beds, and I've got 4 community mental health clinics, which provide services to our patients. And so in addition to those things, the state governments through the hospitals, they also provide emergency departments and various other housing and accommodation programs. So there's a bit of an overlap for a few things, but for most things, there is a clear demarcation of who does what. And private and community sector, as I said, there is a robust private health system in Australia. So people can be admitted in the private hospital. I pay for private health insurance. So those who want to, they can take private health insurance. And so it provides you earlier and timely access. and the private and the public systems work together quite closely. And the government also encourages people to take private health insurance by providing some tax incentives as well. The private health insurance lately, hospitals, because they were generally managing hospitals, they have lately been also focused on trying to prevent relapses. So they've started to offer some out of hospital services as well in order to provide that chronic disease management. I'll talk a little bit about mental health services in Victoria. So most states' system are more or less similar with some minor differences. So Victoria has a population of around 6 million, 7 million. And again, the numbers are similar. 1 in 5 or 1.2 million Victorians suffer from a mental illness. 3% Victorians have a severe mental illness. I think the other data I shared was around 5%. So I think depending upon what you count, it's around 3 to 5% people who need help, but only around 1.16% receive clinical mental health care. So the system has been overburdened and stretched in various ways, so that we're not providing care to everyone. That's a busy slide. I think you just look at it. Some of the things I've already talked about. That triangle, if you look at it, at the bottom of that triangle is the community mental health services. So they provide early intervention, case management, continuing care. Then there is the acute response and triage. The next level is the inpatient services. And the next level to that is the secure beds or long stay beds. And then there are some statewide specialist services for a range of things, including forensic mental health, mother and baby, eating disorder. So for example, in my mental health service, which I manage, I do not have any eating disorder or mother and baby inpatient beds. We share those beds with the other health services which are located in another health service. But we've got some outpatient resources to provide those services as well. And each of these services are divided for children and adolescent and youth, for adult and for aged persons. So in my service, I've got two aged inpatient units, around 16 or 18 beds each. And we rely on another health service, neighboring health service, who provides youth services and child services for our population. So it's a bit complicated in that sense, but essentially the services are divided geographically and they are divided through these age range. And then each of those health services have access to a range of these services, right from residential services, acute and subacute inpatient services, and community services. And then underneath that triangle is a range of other kind of services which are available through the Commonwealth government or through the private health services. All of the health services have to be accredited. I think Rina asked me to mention about accreditation. So I think this is a good website for those of you who are interested in knowing about safety and quality in healthcare. So the Australian Commission on Safety and Quality in Healthcare develops the standards. So we currently have national safety and quality health service standards, and all health services, including mental health services, have to be accredited. So the mental health services in the public system, they are accredited along with their parent healthcare service. So my mental health service is part of a healthcare network, what is called as Northern Health. So our accreditation will be through Northern Health, and then the private hospitals have their own accreditation as well. So these standards are worth a look, and I think Australian Commission on Safety and Quality in Healthcare is probably one of the leading organizations in the world in terms of development of that work. Now I'll talk a little bit about some of the challenges we have. I think we do have time, so I'll try and finish in the next 10 minutes or so. I'll talk a little bit about the challenges we have. So one of our problems is bed-based services. So this is a bit of a busy slide, but if you look at the y-axis, it's the total beds per 100,000 population. Australia has less beds than all OECD countries. Certainly, European countries have more beds per 100,000 population. Since deinstitutionalization in mid-90s, Australia has slowly reduced the number of beds, and that have been realized in the last few years that unless we have appropriate number of beds, we will not be able to provide appropriate services to them. And so that little red thing indicates that in Victoria, we currently have around 22 beds per 100,000 population, and we need to be somewhere around 33 or 35, or actually even higher. And then the other thing which that graph shows is on x-axis is the community context per 1,000 people. So that's another measure we use, that how many contacts are there per 1,000 people. So every time somebody sees a psychiatrist or a psychologist or a nurse in the public mental health system, we call it as a contact. So we just count how many contacts are there. And so if you see some of the services have less contacts compared to other services. So some of that needs to shift to that top right quadrant, both in terms of contacts as well as number of beds. So that there is the Royal Commission into the Mental Health System in Victoria recommended 135 more beds to be built. And so that work is currently progressing. So that's one of the challenge. Our average length of stay is around 12, 13 days. And so and that leads to a lot of people relapsing and coming back into the hospital. The second thing which is quite important is growing demand. So there is a significant growth in people experiencing mental illness. Now that could be simply by the fact that there is a lot more people who are aware and they are seeking help, or it could very well be, as I showed in that initial graph comparing Australia on OECD countries, that Australia and New Zealand have the highest prevalence of mental illnesses compared to all of other OECD countries. And so but there is, if you look at it, there is that growing demand, and especially in the major cities, that graph is actually quite steep over the course of last decade or so. So it's important to recognize that. And so when you have increasing demand with limited resources, then of course the system will undergo a lot of strain, and we will not be able to provide care and treatment to people. There is a lot of focus on suicide reduction, and I think Australia has had data collected more than 100 years now. And so this is a slide which shows you suicide rates in Australia since 1910. And so if you look at it, these are more or less kind of stable graph. It's not kind of going down. There are periods when it has gone up. So this is, in 60s recession and whatever, 2000s recession went up. There are times when it goes down. This is the war, Second World War, I think, or immediately just after that. And a lot of investment has happened over the course of last decade or so. But unfortunately, the rates of suicide have kind of more or less remained stable, both for males and females. And those places where it is high, it has kind of remained higher. Those places where it is a bit lower, it has remained a bit lower. So that is another challenge for us too, in terms of how do we bring those numbers down. One of the things I think is important to remember is during periods of stress, things go up. There are more people with distress. That does not necessarily mean that they have a mental illness or they die by suicide. It just means that they have more distress. And I think that was perfectly evident during the pandemic. If you look at it, it's a busy slide, but if you look at it, these graphs are about accessing various helplines. So these are telephone lines, so Lifeline, Kids Helpline, and Beyond Blue. They are funded by various fundings from Commonwealth and from the state. And so if somebody is distressed, they can pick up the phone and talk to them. And so if we look at it, 2019, which was pre-pandemic, that's a gray line, and it gives you a bit of a number of calls per 100,000 population. That's a baseline. And then if you look at 2020, 2021, it all just went up, especially during the lockdowns. These peaks are during the lockdowns. Melbourne was in lockdown for a lot longer than any other city in the world. So we spent, I think, two periods of almost 6 months in lockdown. So during lockdowns, these calls to helplines went up. But we also saw that during the lockdowns, the rates of suicide didn't go up. So essentially what it tells you is that increased distress does not necessarily mean increase in mental illness, and it does not necessarily mean increase in suicide. So what it just means is that it is just increased distress. And so when you look at 2022, which is the darkest line, ever since things improved, it has been going down. So the call to the helplines have been going down. In fact, for Beyond Blue, it has gone down below the 2019 data. So it's important to remember that there are periods of distress, and during that time, people need to be supported to receive support from their social networks, to look after themselves. But it does not necessarily mean that everyone develops an illness. Telehealth has been a major find of the pandemic, and certainly in Australia was one of the early adapters of telehealth. And again, this graph displays use of this is only the Commonwealth funded Medicare services. And when you look at it at the beginning of the pandemic, that 2020, that light green line, the telehealth was around less than 5%. And when we introduced telehealth, it just went up to 50% within a matter of weeks. And then it came down and went up and down a bit, depending upon what stage of the pandemic we were. In 2021, it kind of went down and then it went up again, because during this period we were in the lockdown. During July, August, September, October, November in 2021, we were in lockdown. And then when the lockdowns got lifted, it went down again. And then in 2022, it's there, but it's going down. So even now, currently, around, so Australia has kind of worked out a long-term telehealth strategy, and we're using it both for the public services as well as for the Commonwealth funded services. And roughly a third of Commonwealth funded services are using telehealth, which is a great achievement, because telehealth, as you know, especially the video, is quite effective, and people don't need to travel. They can save time and money and whatnot. We put some restrictions on telephone use, because telephone has its own challenges. But I think there is some allowance for using telephone as well. But there is no difference between funding for telehealth via video and face-to-face. And I think that's the last graph I'm going to show you before I start to wrap up. So this is online access. And again, this is the data for over a 4-year period. And if you look at it, people who these are the two websites. There is a Reach Out website, and then there is a website, Head to Health. So the bottom one is Head to Health. That's a Commonwealth website, which has got lots of information about different providers who provide virtual healthcare or online healthcare. And so if you look at it again, it was a very limited usage before the pandemic, 2019, the gray line. During the pandemic, it kind of went up and down. And then in 2022 now, it's kind of come back, but I think it's more than double than what it was before the pandemic. And similarly for the Reach Out, it has actually gone even down further. So that kind of tells you that there are variations in terms of how these services are used by people, and there are opportunities for us to actually look at what from this data to understand what can be done to improve access to people, especially those people who might not have a mental illness, who might have what is a psychological distress, or who might be stressed or whatever, that they can access some of these online and other resources to get help for themselves. So really the strengths of the system. So the strength is really, it's a whole of government approach. We do have model of cares which are include specialist services. Of course, there is telehealth is an integral part of the service delivery now. There is focus on all sections of the society in terms of the investment from the governments. There is good access to care and treatment. Emergency access is actually quite good. If somebody was needed to have emergency access, they just go and present to the emergency department or contact the triage, or the community health services will be able to provide access to them. There is reasonable delineation of who needs to do what. So what is done by the Commonwealth government, funded by the Commonwealth government, what is funded by the state government, what's the role of the GP, what's the role of the psychiatrist in private practice, what's the role of the public mental health system. So there's reasonable clarity around that. There are regular reports from the data collected, which drives policy change. Some of these graphs I've shown you, they are part of that data collection, which is there. There is funding for psychosocial supports and other related support systems. There are policy and systems to address inequities and discrimination. There is sustained effort in reducing stigma across the sector. Although I must say that there is reduction in stigma for depression and anxiety, but not much for people with schizophrenia and bipolar disorder. So there is that difference as well. There is quite significant engagement by the governments with professional and non-professional organizations, and there's a development of a strong lived experience voice across Australia and New Zealand. So they are really the good some of the strengths of our system. We do have our own challenges. And so one of the main challenge which has been identified in various investigations is these multiple sources of funding. So the same money comes from different buckets, comes from different places. And so it creates lots of confusion. And many a times we are constantly chasing who's going to fund what. And that includes funding for training positions as well, because we fund training positions through the states as well as money which comes from the Commonwealth government. There is an overlap of service provision between various sectors. So, for example, there are multiple helplines. I showed you data about 3 helplines. So patients don't know which helpline to contact. And the helplines kind of provide more or less similar services. So when you have multiple doors to access, patients don't necessarily understand where they need to seek help. They are more interested in getting help, what is best for them. They don't necessarily are aware of or understand where to seek help. And so having multiple avenues can create confusion for those who are seeking help. It also creates problems for those who are providing help, because they sometimes might think, or you can go somewhere else and they can provide care to you. And they might, so the patients can be kind of sent from door to door before they can actually get help. There are access issues, especially for those with severe mental illnesses. As I said, in Victoria, the data we showed, more than 3% of the population has a severe mental illness. We only provide care to around 1.8% of the population. So of those severe mental illnesses. So we're not necessarily providing good quality care to many of them. And many of our models are episodic care models of care. So we provide care, specialist care to people with schizophrenia. They get better, and then we discharge them back to the general practitioner, and then they stop engaging, stop their treatment, and then they come back. And so we this constantly in revolving door, rather than providing a sustained model of care for those with severe mental illnesses. There is lack of timely data collection. Although there is a lot of data we collect, it's kind of scattered. There are no clinical registries in mental health. There are lots of registries in rest of the health. There are registries for knee replacement, hip replacement, and various things, but there are no clinical registries in mental health. Some of the Scandinavian countries you might be familiar have got very good clinical registries: Sweden, Norway, Denmark, and those clinical registries provide good data in terms of, and then they allow us to drive the policy change. Unfortunately, we've got a lot of data, but our data is kind of scattered everywhere, and it's not providing a timely response the way clinical registry can do. So we don't know whether people with schizophrenia who live in Melbourne, are they getting better services than compared to those who live in Sydney. So a clinical registry might help with that. There is scattered focus on collection of outcomes, but we don't really know whether that investment is resulting in the desired outcome. Perfect example is suicide prevention. We've invested millions of dollars into suicide prevention over the years, but it does not necessarily has led to reduction of suicide rates in Australia. So I think that's another issue where we're investing into various things, but we're not necessarily sure whether it's achieving its desired outcome. And there is quite a significant focus on people with high prevalence disorder and mild to moderate illnesses, but unfortunately, the outcome is actually very unclear. We do have many of these youth health centers called as headspaces, and the evaluation indicates that some of them work well, some of them don't necessarily work well. And so it's kind of unclear in terms of some of those outcomes. Although there is a focus on the various populations, but certainly there is inequity of access due to socioeconomic status and geographic disparity. Australia is a very large country. We got 20% population which lives in rural, regional, and remote areas, and many of those populations do not have the same level of access to healthcare what people in metropolitan areas can have. And then, of course, there are workforce issues. Both the countries are heavily reliant on workforce coming from overseas. So in summary, it's a very complex system with multiple funding agencies. We do have primary, secondary, and tertiary care. The services are based on age range, and they are based on different funding models. The age-based services have a mixture of bed-based and community services. There are specialist statewide services, forensic eating disorder, perinatal personality disorder. Some of them are inpatient as well as outpatient services. And there is quite a bit of emphasis on health promotion, including healthy workplaces, school mental health, and things like that. There are reasonable social services, including income support for people who are on disability, housing support, psychosocial support, and education and vocational support to those who need it. But there are challenges in access and outcomes for many people with severe mental illnesses. Thank you, and I'll stop here.
Щиро дякуємо.
We want to sincerely thank you for this really interesting information,
за такий, знаєте, системний погляд
for this systematic overview and view at the organization of system of mental health in Australia. Right now we have questions and answers time. We already received questions in the chat, but I want to say that before we start speaking about these questions, we have the request to receive the presentation, and our guests want to receive this presentation in Ukrainian. If you agree and provide us with your presentation, we can translate it into Ukrainian and send it to our listeners and guests of this
I'll
event.
send you, Olena, absolutely.
Thank you.
Дякую. Thank you. So there are two questions. How many psychiatric hospitals are in Australia, and how long does the free of charge state treatment take place for patients with depression?
Okay, so in the mental health system in Australia, we moved away from the psychiatric hospitals. So all of the inpatient beds are generally with a general hospital. So, for example, where I manage a mental health service, I have got 3 inpatient units. Each one of them is 25 beds, but that's part of a big hospital. That's part of a big general hospital. And in each of the states, there are different number of beds. But in Victoria, there are around 800 to 900 inpatient beds in total in the public mental health system, and there are around similar number of beds in the private system as well. In fact, actually more in the public system and a bit less in the private system. All of these beds, they are based with a general hospital, except with some exceptions. For example, there is a forensic mental health hospital in Melbourne, which has got around 110 beds, and they are increasing their capacity. That's a standalone forensic hospital. But the general acute inpatient units, they are attached to the general hospitals. And each of the health network, both in metropolitan areas as well as in rural and regional areas, they have a acute inpatient unit. Except the very small rural hospitals, they might not have any psychiatric beds, so they might have to admit their patients somewhere else. But there are those arrangements because it is based on geographic distribution. With regards to patients with depression, so when people are admitted to a public hospital, they don't have to pay anything. It is for free because it is covered by the state government. Those who get admitted into a private hospital, their admission is covered by their private health insurance. And the private health insurance can sometimes ask questions about if there is a longer stay in the hospital. But essentially, they are not necessarily paying for their admission as well, unless they have to pay an access. For example, many people who have private health insurance, they have what we call as an access, that you have to pay a minimum amount every time you go into the hospital. But for the public hospitals, there is no cost to the patient. Most patients with depression, our average length of stay is around 12 days, 12, 13 days. And so most people with severe mental illnesses, someone with schizophrenia, bipolar disorder, or severe depression, I think the length of stay would be around 3-4 weeks, sometimes 5 or 6 weeks. And a lot of people who come in crisis, their admissions are for a shorter duration of time. But that decision whether they need to stay in a hospital or whether they can receive care and treatment in the community is done by the multidisciplinary team, which is led by a psychiatrist.
Дякуємо за таку відповідь.
Thank you for this answer. Also, we have one question, how the system of help to patients is built to the patients who committed the crime. You said that there is a special forensic hospital, but maybe you can say something else?
Yes, so if someone has committed a crime, and so there are two things. One can commit a crime and then they go through the justice system, and the justice system might not send them to the prison. They have various ways how like every country in the world, they try and see that the people can stay in the community. But if someone gets a custodial sentence, as in if they have to go to prison, and if they develop a mental health problem in the prison, then the prisons have mental health services or mental health support from the forensic system. So that is available to them. So if there is somebody who develops a mental health problem in the prison, they have access to a psychiatrist or a nurse in the prison. If they become psychotically unwell, and if they cannot give consent for treatment, then they can be transferred from the prison to the forensic mental hospital. So that can happen. So that is one group of people, those who are in prison and then they develop a mental illness, or they might have a mental illness, but they are not in prison because they committed a crime while they were unwell. So that is one group. The second group is the people who commit a crime while they were unwell. For example, someone kills someone while they were psychotically unwell. During a psychotic relapse, they killed somebody. So that person again goes to the court, and then the court has to decide whether they need to go to the criminal justice system or whether they can actually be seen as having a mental illness defense. And so if that happens, then they go towards a health system, in a sense that they can be admitted to the forensic mental hospital, and what we call as a custodial, on a custodial order, they receive treatment in the forensic hospital. When they get better, and if they are suitable for management in the community, their case can go back to the court, and then the court can decide whether they can be released into the community and continue to receive forensic services in the community. So both those systems work in parallel. So someone who commits a crime while they were unwell, they can receive forensic inpatient services, and they can also receive forensic outpatient services. And when they are released from the forensic hospital or from the prison system, if they need ongoing mental health support from the local mental health service, then they are referred to that local mental health service as well, which can provide care and treatment to them.
Thank you. In Australia, are there daycare inpatient units?
Daycare inpatient units. Okay, so we do have, in the public hospitals, we do not have daycare programs, but we have the outpatient clinics. So people can come to the community mental health clinic, but that's not really a day program. Some of the private hospitals, they run daycare programs. So if somebody's got depression, or if they've got an anxiety disorder, or if they've got some other illness with comorbidities and whatnot, some of them can access daycare programs, but I don't think daycare programs are quite uh, uh, a thing in Australia. Although having said that, the recent inquiries, especially the Royal Commission into the Mental Health System in Victoria, they've recommended establishing of what is called as local mental health and well-being centers. So those centers are in the community, and one of the things those centers are likely to provide, or they will provide, is some form of daycare where people can actually come, receive support, talk to other people, involved in some sort of group program, or whatever other resources are available to them. But unfortunately, as of now, there is not much daycare program outside of the private hospitals. But I think I agree. I think it is something which is really important, because we think that what happened with the deinstitutionalization in Australia, everyone just thought that people can just live in the community and they don't need anything else, not realizing that there is a significant impact of loneliness. A lot of our patients are lonely, they're disconnected from their families, and daycare programs are actually quite helpful for them to connect with other people, but also continue to build on their social skills so that they can live well in the community.
Thank you so much. Maybe somebody else wants to ask a question. Not to write, but to ask this question. You can simply raise your hand and we will give you the floor. So here is a question. Could you give us the list of services which are right now provided online in Australia? Could you give us more information about online services in Australia?
Yes. So there are lots of websites, and I think that is one of our problems. There is just too much. If I'm sure all of you experienced it. If you have multiple points of access and you do not know where to access, then that creates confusion. So there are lots of online services. There is a website called as headtohealth.org, I think. So what I might do is I might actually include that in the email in my presentation so that people can access them. There is a website by Beyond Blue. Some of those crisis helplines, they not only have telephone support, but they also have their own online services. So, and many of those online services, they provide mostly information to people. But some of them, especially this website called as Head to Health, which is a Commonwealth supported initiative, it has actually many providers who provide online services to other people. So it's like really a collection of many other services available online where people can go and access them and then contact them for online services as well as telephone services or for other services as well. But there are lots of websites. Unfortunately, and we have also, as I said, we also have a website for patients, which is our community-focused website, Your Health in Mind. But that's again, our website is more around providing information. So we have to differentiate. There are websites which are there to provide just information, and then there are websites which are there to provide online services more than information in terms of access to healthcare.
Дякую. Ну, я думаю, що з урахуванням часу,
Thank
можливо,
you. I think maybe because we are about to finish the last
людям, які вживають психоактивні речовини і
get
яка
provided, and what is the role of the psychiatrist in this aid?
Can you say that again, please? I didn't hear it. I think because of the connection, it got lost.
як надається
How does the specialized aid provided to people who use substances, and what is the role of a psychiatrist?
Yes, so we do. There is, unfortunately, one of the problems in our health system is about lack of integrated care for mental illness and people who use substances. We know that 75% of our patients smoke. many of them use substances, and alcohol contributes quite significantly. So there are services available to them through the public mental health system as well as through Medicare. There are two main there are inpatient detox services, and there are two main specialties which provide care to that. One is psychiatrist. So we've got a advanced certificate and a faculty for addiction psychiatry. So psychiatrists contribute quite significantly to that. And then the physicians, they also have a subspecialty called as addiction medicine. So there is a bit of overlap between addiction medicine and addiction psychiatry, and they contribute to development of those resources both at the state level as well as at the Commonwealth level. Some of the hospitals do have inpatient bed-based detoxification services. Some of them have outpatient services, but unfortunately, there is more to be done in that space. I don't think we do very well in providing that holistic, integrated care for both psychiatric illnesses as well as substance use.
Thank you. I thought that it was the last question, but here we have a very interesting question from a family doctor. So if I may, taking advantage of being the moderator, let me ask you the final question. Does schizophrenia get controlled by family doctors in Australia? So it's a first question. Do family doctors control management of schizophrenia, and where the family doctor gets trained on mental health specifics?
Okay, yes. So I'll try and answer the second one first. So the family doctor or the general practitioner, what we call them, they do have exposure to psychiatry in their training program, and we've recognized that a lot of mental health care, especially for people with depression and anxiety, is provided by the family doctor. I think in one of the slides I shared that 38% of people who sought mental health support in that year, they went and saw a family doctor. Only 8% went and saw a psychiatrist. But we've also recognized that we need to upskill the family doctors in those skills. And that's why, as a college, we are working with the Commonwealth government to develop a diploma in psychiatry for general practitioners. So that work is happening. But as of now, the family doctors, many of them, they upskill themselves by continuing professional development, by attending workshops, by attending webinars and things like that in management of psychiatric disorders, because they provide care to vast majority of the people who seek help, because they are the first point of contact for them as well. A lot of family doctors, they might be the first point of contact for people with schizophrenia as well, especially when the illness starts or when at the time of a relapse. But generally speaking, what happens is they would almost always seek help from the public mental health service or from a psychiatrist through the private system. The family doctor is mostly involved in monitoring and supporting the person with schizophrenia rather than primarily managing them. For example, people who are on clozapine, and if they are stable, they see a psychiatrist. We have got a program where they see a psychiatrist every 6 months, but they see the family doctor every month for their prescription and for their physical health and everything. So the family doctors play a very significant role in managing people with schizophrenia and bipolar disorder. The problem we see in that space is that many people with schizophrenia, when we discharge them to a family doctor, at some point they decide that they are doing well and they don't need to see their family doctor, and they stop seeing their family doctor. And the family doctors are so busy with many other things, they are not necessarily keen to chase that person, especially when that person says, I am fine, I don't need your help. And so one of the things we are looking at currently is those people with severe mental illnesses, that we retain them in treatment, that they see a psychiatrist every 6 months, rather than be just completely discharged to the care of a family doctor. If the family doctor knows that this patient, if they don't attend their appointments, that the family doctor can contact the public mental health services, then I think the family doctor, the patient and their family, they are all better engaged. And that's what we have seen through the clozapine program. And we're trying to replicate exactly the same thing for those people with schizophrenia and bipolar disorder who are not on clozapine. Those who want to seek help, they go and see a psychiatrist through the Medicare or through the private as well. But those who don't want to, and those who cannot afford, unfortunately, many of them stop seeing their family doctor, and then a few months later or a year later, they have a relapse and they come back to us. So there's more to be done to engage the family doctor in supporting them in providing care to people with schizophrenia and related disorders.
Дуже дякуємо.
Thank you so much, Mr. Vinay Lakra, for this sincerity and readiness to share your information, to tell us and to help us, the specialists in Ukraine, to build the new system of mental health. We sincerely thank you for that. I want to thank all the participants who attended this webinar, who sent questions and actively participated. Also, I want to thank the organizers of this webinar, the executive director of Barrier Free NGO, Oksana Zbitneva. This organization is the partner of the initiative of the First Lady of Ukraine, Olena Zelenska, on the creation of the National Mental Health and Psychosocial Support Program. Also, I want to thank our Ministry of Health and the Deputy Minister, Mrs. Irina Mkichak, and I want to thank the World Health Organization and the head of mental health programs, Alisa Ladek-Brizhalova, and our armed forces of Ukraine for providing us the possibility from the second attempt to have this webinar. We want to sincerely thank all our colleagues from Australia, and I think that our cooperation will continue, and that during Christmas holidays, we want to thank you for taking your time to share this information with us. I want to wish all of you to have a nice day, peace, calm. Goodbye.
Bye-bye, everyone. Merry Christmas. Stay safe. Thank you.
Thank you.